Is Rohit starting off, or shall I?
Rohit is not there, sir. So Vikas is here. So I'm starting the presentation.
Go ahead. Yeah.
So welcome everyone. So
Vikas,
yes,
your screen is not visible. Please
not
present
visible.
your screen.
Okay,
No.
okay.
I can
Yes,
see it.
I can see it. I can see it. I can see it.
Okay. Yes, sir. Yes, sir. It is visible. Please make it on presentation mode.
yes. Okay, so welcome everyone at the third session of the Dermapath. So at Gloderma, we have a vision to elevate the life. So our core purpose is meaningful innovation, unwavering commitment to quality and safety, continuous improvement, result through teamwork, and our aspirational core value is customer success above all else. So at Gloderma, we have a 7 plus a first time India launch product and a 400 plus enterprising Glodermians. And we are a 130th rank in Indian pharma. And we have a 700 plus a distribution network all over the country and 9,000 plus associated dermatologists with us. We have a skilled R&D team and they develop innovative products. So we have a mixed product like antifungals, moisturizers, acne care, hair care, psoriasis care, topical steroid, vitiligo care, and a nutraceutical product with us. So at Gloderma, patient safety is a prominent concern for us. So Gloderma is India's first company to make all products a paraben-free, sulfate-free, and a detergent-free. So we have a flagship brand Moist, the most advanced moisturizers and the cleansers. So Moist, we have a LMF 48 lotions. We have Moist Excel cream, Moist cleansing lotion, Moist daily moisturizing cream, and for the extreme hydration, we have Moist cream, and we also has a Moist synthate bath. So in ketoconazole range, we have a Q1, the advanced upper solubilized ketoconazole in a lipid phase. So whatever ketoconazole used in the Q1 is solubilized in the lipid phase for longer penetration. So in Q1, we have a ketoconazole lotion, which contains the Q1 2%. We have a Q1 soap, Q1 zip shampoo, and Q1 tablet and cream. In Minoboost range, we have a Minoboost and Minoboost app. So both are the completely alcohol-free, and Minoboost come with the 360-degree spray applicator and a droppers. Introducing a first time in India, we have a novel non-fluorinated topical quinolone, which is a Ozedix, which contain ozenoxacin. So it's come in a ozenoxacin cream and lotion. So for a baby care range, we have a Sanosen Baby, which is a made in Germany, which is a premium pediatric skincare. So Gloderma has an international collaboration with the Man and Shoulder Cosmetics company, which brings the world-class Dermatest certified with a natural safe baby skin products to Indian mothers. So in Sanosen Baby, we have a Germany's premium baby skincare range. So in Sanosen, we have one globe, one formulation. So whatever formulation used in Germany, the same formulation used all over the world. We have a 40 years plus expertise in baby skincare, and Sanosen is present in more than 70 plus countries. So Sanosen till now gained a trust of Indian mothers 250,000 plus. And in Sanosen, we have a more than 90% of a natural ingredients. All Sanosen product is SLS, SLAS, paraben, phenoxyethanol, and silicone free. Sanosen have a 5-star guaranteed rating, and it is clinically tested and hypoallergenic. So in Sanosen, we have a bath and shampoo, Sanosen care oil, Sanosen cream, Sanosen sunscreen, and Sanosen lotion. So all Sanosen product except sunscreen are recommended from day one, and sunscreen is recommended from 6 months and above. So that's all about a Gloderma. Thank you so much, Sasi sir. Over to you, sir.
Thank you very much, the Gloderma team, for sponsoring this meeting and arranging everything. So, welcome everybody. So, we have 3 participants who are the winners from last time. So, welcome Dr. Payal, Dr. Sanjay, and Dr. Lavanya. May I please start with Dr. Lavanya to introduce yourself, and then Dr. Payal and Dr. Sriram, and then we can proceed with the meeting.
Good afternoon, everyone. I am Dr. Lavanya, Professor of Pathology at Sri Venkateswara Medical College, Pondicherry. I'm happy to be a part of this quiz. Thank you, sir.
Dr. Payal.
Good afternoon, sir. Good afternoon, Nandakumar, sir. I am another panelist who joined. I am Dr. Payal Chauhan. I am Associate Professor and in charge in Department of Dermatology in AIIMS, Vijaypur, Jammu.
Dr. Sriram.
Good afternoon, everyone. So I'm Dr. Sanjay Sriram, Assistant Professor of Pathology from JIPMER, Pondicherry.
Excellent. Welcome all to the third DADI CPC meeting. So hope all of you have taken the quiz questions. So what we'll be doing in rotation, we'll be asking each one of you to just describe the findings. I'll start off the first case, which Dr. Nandakumar sir will moderate. Dr. Lavanya, if you don't mind, we'll go with the first case, okay? Are you
Yes,
ready?
sir. Yes,
Oh,
sir.
I'll share the screen. Okay, so case 1 is a 16-year-old male with asymptomatic skin lesions across the body for 2 years, accompanied by mild intermittent itching. So these are the clinical photos. I'll just show them one by one. So here's the histology. Dr. Lavanya, Dr. Nandakumar sir, do you want to just take over, and then I'll just show the slide accordingly as per your wish, and then Dr. Lavanya can probably describe the findings.
Describe the findings.
Okay, sir. So section study shows skin with, we can see aggregate of collection in the superficial dermis without any Gren zone. And these infiltrates are composed of histiocytes with abundant eosinophilic cytoplasm and vesicular nucleus with prominent nucleoli. Some binucleation and multinucleated histiocytes were seen. And also seen are some neutrophilic infiltrate within the infiltrates.
What is very striking is the focal nature of the infiltrate, isn't it?
Very focal collection, yes, sir. And the epidermis was not involved. It is only in the dermis without any epidermal involvement.
With the scanner view, do you suggest any possibility? We saw the clinical photographs, no? The
Yes,
scanner.
sir. I actually thought of xanthomatous lesion kind, looking at the clinical photograph. And this is like a localized collection in the dermis, composed of histiocytes with abundant eosinophilic cytoplasm. So my first differential diagnosis was reticulohistiocytosis, and other histiocytic disorders has to be ruled out.
Yeah, it is a histiocyte-rich focal infiltrate.
Yes,
and
sir.
correlating with the clinical findings, a possibility of a type of histiocytosis has to be considered. Did we see any multinucleate giant cells?
Yes, sir. In the lower field, here I can see one.
One multinucleate giant cell is also.
Yeah. Most of the histiocytes have dense eosinophilic cytoplasm. Some are vacuolated, but most of them appear to have a dense eosinophilic cytoplasm.
Yeah,
Can
the
any-
histiocyte. Yeah,
Sorry,
please,
sir,
please.
go on.
No.
So can any influence be drawn from the type of giant cell, ma'am?
It looks like Langhans type.
Yes,
Can we
it
go
is non-specific, right? I mean, it's not really specific to any entity.
Yes, sir.
Go ahead, sir.
So once we see it under the high power, I think the possibility of a xanthomatous lesion is out, isn't it? The histiocytes are different.
Yes. Yes,
We
sir.
have to consider possibility of some type of a histiocytosis. It's a relatively young patient with multiple small lesions.
Yes, sir.
When we actually discussed the slide among us, we clinically, one possibility, by clinical appearance, one possibility that we considered was it could be like a nitidus, by clinical appearance. And the histopathology in the scanner view, the infiltrate is very focal. And in like a nitidus, one can get histiocytes. But when we go closer, we see that it is not like an introduce. The histiocytes are far more numerous than what would you expect in like an introduce. So this is definitely a type of histiocytosis. And how do we work up this case further?
So we have to do immunohistochemistry for histiocytic markers, CD68, S100, CD1A.
Yeah.
So
And these were done in this case, isn't it, Dr. Shashi?
Actually, in this case, this is the first case. The patient hasn't yet come back for the or the clinician hasn't yet asked for paid for the investigations for the IHC. So we didn't do it actually. So we went by the clinical and gave the clinician the histopathology report with the differentials that this is a histiocytic disorder, and we need immunohistochemistry to narrow this down further. But I think the patient is from a government hospital and they cannot afford. So I think they are proceeding based on the clinical appearance and going ahead with management as per the patient's affordability, I guess.
Putting together the clinical features and histopathology, I think the most possible diagnosis that we can offer is an eruptive kind of histiocytosis.
Yes. Yes. Yeah, because the eruptive histiocytosis, but it's not a JHG because you don't see the typical, the typical histiocytes, the giant cells that you see in JHG. Any other particular features that can help us? Anybody else in the panel wants to comment?
Sir, may I add something?
Yes, Dr. Lavanya, go on.
Dr. Payal, sir.
Dr. Payal, yes, go on.
Sir, clinically, when I saw the patient, it looked a lot like non-Langerhans cell of histiocytosis. So the generalized eruptive variant of non-Langerhans cell histiocytosis should be kept in the differential.
Yes.
Because otherwise, had the lesions just been on the face, then benign cephalic histiocytosis would be. But because it is involving the trunk also, and it has been found in generalized eruptive histiocytosis, which though occurs in young adults, and the male is 16-year-old male, and because we are also able to see histiocytes in the histopathology, so probably generalized eruptive histiocytosis, as sir mentioned, eruptive histiocytosis is one variant that we must keep high up in the.
Yes. And is there any clinical implication to naming it as a different variant when it's eruptive anyway? Langerhans, non-Langerhans, how does your histopathology report affect the clinical management?
So the systemic involvement tends to differ in these histiocytosis.
Yes.
So that's why we need to, because systemic involved, usually we get all the systemic workup done, but
Yeah.
other in Langerhans usually skull involvement, other bones involvement, we have to look at that. So that system is involved.
Yes. So yes, that is what. But given that the patient is pretty well, I don't know what investigation have been done. This is a fresh case. I just put this here for discussion because that is what is more important. Is that we recognize that this is histiocytosis, Langerhans, non-Langerhans. That depends on immunohistochemistry. That is very important. In this case, it was not done, but I thought this is a good case to discuss. So let's see
Sir,
what everybody else has answered. So we've got 34 participants who've actually answered. 5 have called it lichen nitidus, and we understand why, because clinically that may be possibility. But then histologically also, it's an infiltrate confined to two with enclosed by two wetting ridges. But then it's not lichenoid granulomatous. It's clearly a histiocytic infiltrative disorder rather than being a pure granulomatous disorder. So that's why it's not lichen nidus. For those of you who are wondering why it's not lichen nidus, generalized histiocytosis, what could be is the right answer. So Dr. Nandakumar sir, we're giving it 1, right?
1 mark. 1 mark.
Eruptive xanthoma, I don't think we're giving it anything. Are you giving anything for eruptive xanthoma?
No marks.
And eruptive syringoma, 0. Langerhans cell histiocytosis.
No, we cannot give.
Yes, it's really not. We can't really call it Langerhans cell because it's not Langerhans cell histiocytosis. That's completely different entity. And as Dr. Payal has already said, the huge clinical implications of calling something Langerhans cell histiocytosis versus non-Langerhans cell. So we can't really call that. Actinic lichenitis again has to be a 0. Molluscum contagiosum 0. Multicentric reticulohistiocytosis. Again,
See, the cells will be very bizarre and we get numerous multinucleate giant cells and all. And as we were discussing, the clinical implication is also different. This is not the appearance of multicentric reticulohistiocytosis. This is the focal infiltrate. The other one, we find a diffuse dermal infiltrate.
Yes.
Bizarre looking histiocytes.
Yes, so I don't think we're giving any marks for that either. Acantholytic AK, accessory tragus, I don't know where that came from. Trichoepithelioma, multiple familial.
This non-Langerhans cell histiocytosis, I marked it non-Langerhans because somehow when I was typing generalized eruptive wasn't coming.
That's okay. I think non-Langerhans cell will go there. Non-Langerhans cell histiocytosis can be given marks. What do you think, sir?
We can.
How many marks are we giving it out of 1? We have 0.75, 0.25, 0.5 also. So what are we giving? Because it is there. Eruptive histiocytosis is there. Generalized eruptive histiocytosis is there in this thing. You specifically called it non-Langerhans cell, which is also not wrong. But then, Dr. Nandakumar sir, how many marks out of 1?
Maybe 0.5.
0.5 on that one. Okay. Okay. 0.5 for calling it non-Langerhans cell, which is a good answer. Not wrong. Histiocytic sarcoma, I don't think we're giving any of these. Juvenile JXT also, I don't think we're giving any of that because that's not the typical histological appearance. For the same reason, reticulohistiocytosis also, I don't think so. I mean, but if we want to give 0.25 for calling it a histiocytic disorder, we can. What do you think, sir? I mean, if you're calling it all...
Too vague an answer.
Too vague, shall we leave that off? Okay.
Yeah, we will leave that.
Okay. So no marks for any of that. Even xanthogranuloma, I guess, falls into the same category. So shall I close this case then? Case 1?
Go to the next.
Fine. So case number 2 is itchy raised lesions on the buttocks for 2 months, well-defined plaques with central atrophy and scaling, pigmented margins of the buttocks, intense pruritus, but there was also depigmentation on natal cleft. Did not respond to antifungus and partial respond to steroids, and the clinician was wondering if it's lichen sclerosis. So that is the histological picture, clinical picture. You can see here these whitish sort of sclerotic lesions and not sclerotic clinic. I mean, clinically, on picture we can't make out, but they're whitish lesions. So maybe Dr. Payal, you can go through this histology and let us know what you think on low power.
Sir, on low at this power, I thought that there's some homogenization of collagen when I just saw it for the first time. But then when I zoomed in, I thought that the margins, like the borders are not squared up, and then I didn't see the other findings for morphia per se. So because also the LSA was in the BD, so my mind went there initially. But then I scanned it for a very long time. Then I went to the epidermis, and I thought I saw something in the epidermis. Might be wrong. I because there was also a pass along with this, so I did feel that there was some evidence of hyphae that I saw. So this probably, yes, this is what I found. Then then I went to, so I saw the slide number of times, 2, 3 days, and then I wasn't sure for anything else, and then I had put tinea for this because I saw this, and I don't know if it's fungus or not, but then I saw it on VMS also, and I thought this would fit into because of the high phase that I saw.
Yeah. This is a clear-cut case of tinea. You're quite right, actually. You can see the hyphae even on H&E. You don't need a PS for this. You're seeing the hyphae even on H&E. All these are hyphae in the stratum corneum. You can see these blue structures. They're all hyphae. And if you go to PS, that's it's not a great PS, to be honest. It's not one of the best passes my technician's given. But you
This
can
is a
see.
clinical diagnosis for LSA, which tends to, gives you a little like, am I missing? I mean, is there something that I should be looking in the dermis? But then I think it's a steroid modified tinea because I don't see the raised borders, and probably it's been treated with steroid. That's
Yes.
why the clinical doesn't fit into the.
Absolutely. And the numerous hyphae, I mean, the hyphae cannot be missed even on H&E. I mean, you can see the hyphae beautifully on PS. You can see that. It's a very dark PS here, not a great stain, but you can see the hyphae. I mean, they're beautiful. But the thing is, you don't need a PS for this particular case because you're seeing PS even on H&E. I mean, you can't miss them. They're everywhere. So yes, if you didn't have the PS and the clinician didn't tell you the history, and this was a case of PV LS, well, morphia, you can confuse this for morphia maybe, but not for LS because LS should have an atrophic epidermis and the collagen should be quite sclerosed here. For the buttock and for the trunk, for the thigh, this collagen is normal. And that's very important to realize that when you send a case of is this morphia or LS from the trunk, from the thigh, this is a normal biopsy in this particular area. And the collagen can look thickened. So we should not confuse this for morphia or LS. And that is an important learning point. Apart from the fact that you should always do a PS when tinea in any form is suspected. So any other comments from the panel?
Yeah, can I make 2 points? One, I think this slide tests the observational skill of the person looking at the histopathology. We have to be very diligent in going step by step while reading a histopathology slide. That point gets highlighted by this particular slide. Second point, which I would like to stress, is that just by seeing the fungal hyphae, we shouldn't jump into the conclusion that it is nothing but dermatophytosis. We should remember that it can coexist with another pathology, like perhaps an LSA or morphia or whatever it is. So we have to exclude that also. And there is no findings of LSA or morphia in this slide, but I just wanted to make that point also because superadded fungal infections can occur especially in these kind of anatomical sites. So these 2 points I would like to stress.
Absolutely, sir. I've seen cases. I recently saw a case of tinea with, I think it was one more condition actually. Tinea with pemphigus, I think. Both of them coexisted. Tinea with psoriasis, both of them coexisted. Both patient had both. So yes, it is always possible that there is a second diagnosis which we should not miss. Yes, indeed. And the clue of even if you're not seeing hyphae on H&E, the clue is that LS will have more of an atrophic epidermis, and that's what we need to look at. And also the parakeratosis is a clue. You don't often get this compaction or focal parakeratosis in LS. Usually there is, it's usually orthokeratosis that you often see. So let's go to the answers. So case number 2, 11 out of 34 people have called it LS for some reason. I think they're just going with the clinical, and I guess as Dr. Payal has said, they were confused by the histology, the dermis being a bit thickened.
And the clinical picture, perhaps.
And the clinical picture, yes, yes. So tinea and dermatophytos, that's the only one that gets 1 point. I don't think we're giving tinea nigra also. We're not giving any points, unfortunately. This is not tinea nigra. Do you agree?
Yes, so tinea nigra is usually on the palm.
Yeah. That should not be given any points. And I don't think we're giving anything else, any other points. So I'm submitting this and closing the case. So only
Sir,
7 people.
sir, may I ask thing?
Sorry, anybody wants to
Sir,
speak?
I have a small doubt, sir. Can I?
Yes, sure, go ahead.
Sir, as far as I read, they said if it's in abundance and if there are lots of hyphal filaments, then tinea nigra is the most common possibility rather than a tinea versicolor. Because what they said is
See,
most often
nigra is a complete different clinical entity. And
okay.
this is not versicolor anyway. This is just tinea corpus, normal superficial dermatophytosis. But the reason for the hyphae is actually the steroid modification. Because the patient was using steroids, that's the reason there's so many hyphae. That has nothing to do with tinea nigra. May have more hyphae, that is fine. But just because something has more hyphae doesn't make it tinea nigra, if you understand that. Tinea nigra is a clinical entity.
Can I add a point, sir?
Yes, go ahead.
So tinea nigra, the name is nigra. So nigra is because it's pigmented variant. So usually tends to happen on the palm. So nigra is because of the pigmentation, brown pigmentation that you see in the lesion. So this lesion was more like hypopigmented in the center.
So the nigra is not due to the pigment which we see on HE. I mean, HNE had this somewhat golden brown pigment.
Clinically wouldn't fit, no? Tinea nigra clinically wouldn't fit this.
So clinically wouldn't fit. Okay.
That's why, because it's clinically, so it's a CPC na, in the end. So you have to see what the patient has clinically and then correlate with the histological features. So clinically, tinea nigra wouldn't probably come in here. Clinically.
Okay. Thank you.
Like Sir said, it's a different entity altogether.
Okay. Thank you.
So I guess that's where CPC comes in, because you need to know that you need to have a bit of clinical overview to understand the histology. Because if you're only reporting histopathology and not looking at the clinical, that's where the confusion arises, and that's where pathologists, pure pathologists, are at a loss because they don't see the clinical often, and that's a good learning point actually. So case number 3, Dr. Sriram, you can probably take this up. This is the clinical 60-year-old female. This probably is easy for you. 6-month history of a gradually progressive mass on the right temple, occasional pus and blood discharge. So this is the clinical, if those of you haven't seen it. I mean, here it's not zooming up well, but it would have zoomed up nicely in the quiz. Here the image is a bit distorted. So Dr. Nandakumar sir, Dr. Manoj Singh sir isn't on board. I don't know why, but maybe you can go through this case with Dr. Sriram.
Please, doctor, can you just briefly describe the findings?
Yes, sir. Sections is showing only tumor tissue, sir, on low part. No normal epidermis or normal dermis is identified. It's composed predominantly of tumor. And going on high part, the tumor is kind of infiltrative, has a desmoplastic strength at points. And apart from that, the tumor is arranged more often in islands and vague nests. And it is exhibiting lots and lots of pleomorphism, high mitosis, and a very prominent nucleoli. So with the desmoplastic stroma, it has, I thought, and also it has some amount of onion skinning and keratin differentiation is also there. So I was thinking more of a squamous cell carcinoma. No specific type, sir. I mean, I couldn't fit into any specific type per se.
Yes, this is actually, I mean, would you call it as well differentiated, moderately differentiated, or poorly differentiated?
Sir, I would go for moderately differentiated squamous cell carcinoma because the number of squamous eddies or squamous pearls which you are seeing is not more than 75%. It is less. So I will go for a moderately differentiated squamous cell carcinoma.
We wanted people to identify the squamous differentiation, which is seen only in some focus. Otherwise, what all differential diagnoses will we consider? Leave alone the squamous. Please.
Sir, even if any tumor is showing just a squamous differentiation, it does not always make it a squamous cell carcinoma. We should consider adnexal tumors with squamous differentiation also. But I feel in this case it was, I think I am little biased because, I mean, I see squamous cell carcinoma routinely and it was more situated in the temple. So which is not a common site for any adnexal tumor is what I felt, sir. So
We are seeing the
that's it, sir. I
highly
mean, apart from
prominent nucleoli and all. Forget the
yes,
squamous differentiation. Will we consider a melanoma, a melanotic melanoma in the differential diagnosis? If we forget the
definitely, sir.
squamous differentiation.
Yes, sir. Then we can think of even epithelioid sarcoma,
Yes.
amelanotic
Yes.
melanoma,
Yeah.
clear cell sarcoma. So then the spectrum gets much more widened.
So
But
can
here I think
focal keratin differentiation be seen in any of these tumors? That's a question, I guess. Because we don't have IHC on this one. I haven't given IHC. So can focal keratin differentiation be seen in any of these tumors? And will that, is the keratin differentiation prominent enough to call this SEC? Or can we consider any other differentials that we've discussed if somebody has posted, given that as the answer?
The epithelial sarcoma doesn't show squamous differentiation, so that is more of an out. And melanomas also don't show squamous differentiation. But anyway, if clinically, if there is a suspicion of any adnexal tumor, especially hair follicular tumors, then we might give a thought. But I personally didn't see that much of any basiloid cells or that a very condensed stroma, which is usually seen around the tumor nest. So those are not there. So I personally think this is a straightforward case of squamous cell carcinoma.
yeah, even the clinical picture is very suggestive. A cauliflower-like growth, isn't it? With the squamous differentiation of cells. I would perhaps call it as moderately to poorly differentiated squamous cell carcinoma. That's all. Any other comment from our two panelists? Dr. Lavanya?
Sir, I also felt it is a straightforward case of squamous cell carcinoma, moderately differentiated.
Moderately differentiated. Yes.
Okay. It's interesting that people have called this moderate differentiated because I call this poor actually. In my case, I call this poor because the squamous differentiation is very focal, probably less than 10%. It is there. So you can call it a squamous cell carcinoma, but the squamous differentiation is very focal in my opinion. I mean, there are a lot of mitotic cells and everything, so it's definitely malignant. But yes, I guess there's a spectrum in poor. The extremely poor differentiation, you can't even make out any keratin differentiation. But
Yes.
I would prefer moderate. See, in my opinion, focal keratinization, keratin differentiation, I have seen in melanomas, amelanotic melanomas, focal keratin, because the melanoma is arising from the epidermis. So some of the epidermal keratinocytes are bound to be affected by it, and when they're caught in the midst of melanoma, especially in the cross-cut section, one may see a bit of focal keratin differentiation. So, not in this case, but in general, just because you're seeing a bit of keratinization in a poorly differentiated tumor, I don't think you can be so confident as to call it a melanoma, call it a squamous cell carcinoma per se. That's my opinion. Nandakumar sir, what do you think? Are you
I would call it as
favoring?
poorly differentiated squamous cell carcinoma, but I mean, it is always better to confirm with the IHC also.
Yes. I mean, can you be 100% certain that this is not a melanoma is my question.
Yeah, that is what I said. It is better to, I mean, histology wise, it is in favor of a poorly differentiated squamous cell carcinoma.
Yeah.
To be confirmed by IHC.
Yes, yes. But if somebody has given, I don't know if anybody has given melanoma as the answer, let's see what the answers are and we'll probably discuss. This, I think, has
So
been submitted.
we cannot give credit for malignant melanoma with this result.
Let's see. So squamous cell carcinoma, 13 out of 36, which is good. So that's anyway one. I don't think BCC can be given any points. Pyogenic granuloma, JNK, I don't think can be given points because I don't think there's any suggestion of a K anyway, clinically also. Sebaceous carcinoma, again, I don't think can be given. Do you think? I don't think so. There's no sebaceous differentiation. Squamous cell carcinoma, no special type. What do we think of this? I mean, is there any squamous cell carcinoma poorly differentiated? Let's see. Yes, there is one squamous cell carcinoma poorly differentiated. There's nobody has given moderate differentiated. Only one person has given poorly differentiated. So we, I guess, have to decide whether to give any marks for pure squamous cell carcinoma without any differentiation. Then decide on whether to give any percentage out of that to no special type and poorly differentiated. What do you think, sir?
I think for moderately differentiated as well as poorly differentiated, we will give 1 mark.
Yeah.
Squamous cell carcinoma without any differentiation, I think only 0.5 can be given.
0.5, yes, I think so. I agree.
Sir, but I think moderately differentiated was not in the options.
Was
Because
not in
I
the
tried
option?
and
Yes, sir. It was not there in the option.
Let me, okay, let me just check while I am here. Sorry. Let me just check if it's there. Because all the answers should be visible here. Squamous cell. If that is the case, then we can do that. Squamous cell carcinoma, basaloid, no special type. Sorry, just a second. I didn't check for moderate differentiated. Poorly neuroendocrine, in situ spindle, no special type. I guess, okay. So if no special type, I guess if that is the reason, then no special type. In that case, we probably have to give even squamous cell carcinoma the full marks, because moderate differentiated was not in the answer. What do you think?
We have to.
Yeah. So, okay. So we'll give everything 1 point on this case, in this case. So one for, oops. One for squamous cell carcinoma, one for, so I don't think adenoid squamous, I don't think we are giving points
Any
because
mark.
that, what do you
No
think?
mark. No mark.
No mark, yes. And BCC also no mark. And basosquamous also, I don't think it's not really a basosquam. I don't know.
No, there is no basal cell, basaloid differentiation.
Yes, yes. And in situ definitely is not the answer. Metastasis, eccrine porocarcinoma, I don't think it's an eccrine porocarcinoma. Malignant head neck cell tumor. I guess if we want to give some points for malignancy, we can, but we have to decide on that.
Malignant head neck cell tumor, perhaps 0.25.
0.25, maybe, yes. I don't think we're giving anything for adenocarcinoma or anything else. Again, sweat gland carcinoma, again, this is very specific. I don't know how they've gone for that. Okay, so I guess we'll close this case on that. Is that okay?
Yes.
Okay.
I hope the panelists attended our last session where we discussed a tumor with sebaceous differentiation. Discussed it
Sebaceous
in
differentiation,
detail.
yes.
Yeah.
Yes, yes. So, Dr. Lavanya, this is back to you again. 4-year-old,
Yes.
7-year-old boy with a solitary dome-shaped papule on the foreskin. Since 3 months, asymptomatic. I think this is a straightforward case which we can close straight away if you're happy with
Yes,
it.
sir. So you're basically seeing a well circumscribed nodular lesion, which epidermal proliferation. And at higher power, we can make out the molluscum bodies. HB bodies can be made out in the cytoplasm.
Yes.
And as they go to the granular layer, they become hematoxyphilic color. So these are the characteristic molluscum bodies. So the diagnosis is molluscum contagiosum.
Yes, I think Dr. Manoj Singh's case, this is, he's not here in the panel for some reason, but I think the reason he put it is because for you to identify the endophytic nature, because normally molluscum is an exophytic lesion. This is an endophytic lesion. So you see an inverted type of molluscum. Can you make that out?
Yes,
This is
sir.
not exophytic. This is endophytic. So this is unusual about this case of molluscum. That's why he thought this was an interesting case. It's not the usual exophytic lesion. Anybody has got any other things to comment, or shall we move to the next case? Or move to the answers, rather?
I think the striking feature is that this is an endophytic lesion.
Yeah.
So molluscum can occur as an endophytic lesion also.
Yeah, yeah. So let's see the answers actually on this one, case number 4. So 28 have called this molluscum. That's good. So I don't think there are any marks for anything else. Condymon accumulatum, somebody has called it for some reason. Okay. So I'm going to submit that. I don't think there's any controversy in this. 28 people have got it right. So case number 5. So back to you, Dr. Payal. So Dr. Nandakumar, sir, you can go ahead with this. So this is the clinical photo, 28-year-old female with itchy papules around the mouth, and the biopsy was taken from this particular part rather than the upper lip where you see the papules. Apparently there was some scaling here as well and some papules which you can probably make out actually. So that's the biopsy, and DD given was granulomatous cheilitis by the clinician. So this is the histology.
Sir, I found parakeratosis, total parakeratosis in there.
Dr. Payal, maybe you can start with just a low power description and then you can go on to the higher power.
Yes, sir. So what I see is epidermis and the biopsy comprises of epidermis and dermis. And on low power, I also see some focal para. And then I see that there's some element of spongiosum and some inflammatory infiltrate, which is mostly upper dermal inflammatory infiltrate. I don't, I mean, this is, the infiltrate is mild to moderate, not very intense at this part. And then
I mean, what is the hyperplasia like? What does it
yes, sir,
present?
there is epidermal hyperplasia. It's regular, irregular, sir. Regular epidermal hyperplasia is there. So there is a canthosis and papillomatosis and epidermal hyperplasia is there. Then there is some spongiosis and there's I'll have to go high power where I also see a bit of spongiosis and dermal edema at one point, and then I'll like to go to higher power to check the nature of the inflammatory.
So anyway, this is not granulomatous vasculitis.
It doesn't no collection of cells. No,
That part we are clear. What else? What lesion will we call this as with the clinical picture, Dr. Payal?
So it's looking what clinical lesion.
And what would be the diagnosis? How do
I would
we?
like to keep it dermatitis spectrum, the contact dermatitis or eczematous cheilitis spectrum. And then the papules on the upper lip, like I like to take the history of the patient if he's applied any again steroids and then he's left it for periorificial dermatitis and allergic contact dermatitis or eczematous cheilitis spectrum. So I was more towards the eczematous cheilitis and allergic contact dermatitis spectrum with this because then I see the focal parakeratosis also here. And infiltrate is predominantly lymphocytic, though I try to find for some EOs also, eosinophils, but then it didn't come across. And some dermal edema and some spongiosis. Spongiosis is
We also think on the same lines. It could be an eczematous cheilitis, but seeing the histology alone, I mean, is there a psoriasiform hyperplasia? That is what I
Yes, sir.
want. Yeah.
Psoriasiform hyperplasia is there.
Yeah, there is a bit of a psoriasiform hyperplasia. That is the, thing to remember. This sort of picture can occur. Again, if we do not take into account the clinical picture, we may sign this off as psoriasis. So that is the learning point from this slide with the focal parakeratosis and all. And a psoriasis with eczematization or an eczematized psoriasis or whatever it is. But seeing the clinical picture also, taking that into account, we understand that this cannot be psoriasis and this is the kind of a spongiotic dermatitis. And as Dr. Payal rightly said, you call it as an eczematous cheilitis, perhaps. Good diagnosis.
So one thing I want to highlight also here is you need to be able to identify the site from the biopsy, and these are beautiful.
striated muscle.
And you can see beautiful muscle bundles here. And sometimes these are very helpful when we are signing out because mixing up of samples is very common. I mean, not very common, but it doesn't happen so infrequently. And these are the signs that help because somebody, the next biopsy may be query psoriasis in another patient. And then you look at the sample and you know that, okay, this is not psoriasis, this is actually a biopsy from the lip or the genital area maybe. But the other biopsy was from the forearm. And then you can make out that the sample got mixed. So it is very important on low power to identify the site before we go to anywhere else. It is very important to just double check the site, identify the site and make sure the site is correct. And then, of course, the psoriasiform dermatitis, the learning point is you can see all the features of psoriasis. So if this was a case from the trunk and is it query psoriasis was the clinical differential, you would sign this out as psoriasis. I don't think there are any doubt about it, apart from the muscle fibers.
We should read the request form very carefully. First, we look at the slide and then read the request form very carefully, whether the site of biopsy has been mentioned or from the histology, we can make out the site of biopsy. All these points, small points are very important preventing us from committing mistakes.
And
Sir,
that is
I
the
have
reason
a
I put
doubt.
in a routine sign out. This is not a special case. This is a very routine case. But I thought this is very important as a learning point. This is psoriasiform dermatitis, and then but then this is not psoriasis, and that's a very important learning point.
Sir, I have one doubt, if you could clarify kindly. So the parakeratosis, would you just write in your report focal parakeratosis, or would you also say with plasma exudate or something? Would you mention that for the corneum?
There is no
Better.
plasma exudate here, but I don't think that matters.
The fibrin globules, do you think? I mean, no, sir, scale crust, no. I mean, would you call it that there is scale crust present? Would you say that?
You can, but how does it change the differential? I think your differential won't change, no? Your discussion in differential.
I just want to know the findings that you would note down in your report.
Yeah, I didn't specifically mention scale crust. I just said parakeratosis because I don't see any fibrin. I didn't see any globules or anything, eosinophilic globules. So I don't think I mentioned any of that. I mentioned the psoriasiform dermatitis with focal spongiosis and parakeratosis. And then the important thing to remember is that wherever there's parakeratosis, spongiosis, there's always hypogranulosis. So that doesn't make it psoriasis. And given the clinical history, I said this is in the eczema spectrum to rule out contact dermatitis and other things. And most importantly, I've ruled out granulomatous cheilitis. Have we ruled out perioral dermatitis is the next question, because that is the other obvious clinical differential in this case. What do you think, Dr. Payal? Have you ruled out perioral dermatitis, or does it not matter?
Sir,
Or does
I've
it matter?
when I thought that it could go, because the clinical presentation was, though there's उसमें 1 mm of margin, that margin is spared in periorificial dermatitis, but the papules were there. I wanted to know if there is any history of steroid. Histologically, I don't know, sir. It's also, I mean, I don't think it histologically one would be able to, I mean, you could enlighten me further if histological any finding is very specific for periorificial dermatitis. In the end, it's dermatitis. What differentiates is the clinical presentation again.
What do you think, Dr. Lavanya and Dr. Sriram? Do you think periorificial or perioral dermatitis has specific histology, or is it non-specific?
I feel it has a very non-specific histology, sir, just like any spongiotic tissue reaction pattern. So I don't think anything is there. I think clinical presentation will be the main key, which, as ma'am said, that some amount of margin around the lips.
Dr. Lavanya?
I also feel the same, sir. It will come under spongiotic dermatitis. Periorificial will not have any specific features.
Nandakumar sir, what do you think?
Yeah, even the only thing is, in these cases, the biopsy would be a last resort. So already the patient would have applied steroid and whatnot. So all those changes of topical application will also be there. The biopsy finding. That's all.
Yeah, in my experience, the perioral periorificial dermatitis is not just a dermatitis that usually has an acneiform component, and the papules are really folliculocentric. And you often have a perifollicular infiltrate. And this goes into the rosacea, acne, agnata spectrum. If you call it periorificial dermatitis.
I
That
fully
is
agree.
one.
Sometimes, the differential would be from rosacea.
Yes. So periorificial dermatitis, even if you look at textbook, has got a very specific histology. It's not just dermatitis that occurs around the mouth. Dermatitis that occurs around the mouth, say in eczema, in atopic dermatitis and other entities like contact dermatitis, has this picture. But if you're talking about the papular eruption typical of periorificial dermatitis, or acne agnata or face or whatever you want to call it, that usually has a folliculocentric specific infiltrate. So that is a very specific entity. So if somebody is calling it periorificial dermatitis, I personally have a problem with that diagnosis in this particular case on the histology. That is my opinion.
Agreed.
Let's look at the answers anyway, see what everybody has called it. So 9 people have called it periorificial dermatitis. That is where I'm getting at. Personally, I would give this 0, but if you want to give any answers to it, Nandakumar sir, I'm open to.
We cannot give marks for that, periorificial dermatitis.
Yes,
we cannot.
To me, that is a specific diagnosis that usually needs to have this folliculocentric granulomas, not necessarily granulomas, but at least a folliculocentric infiltrate, which are not seen here. So the only answer to me is a dermatitis spectrum, which is chronic spongiotic dermatitis. I would be happy to give 1. Do you agree, sir?
Yes.
And I don't think answers are valid for anything else. Seborrheic dermatitis, again, this is not the clinical nor histological picture. Histological picture, certainly yes. I don't know. What do you think? Do you think seborrheic dermatitis should be given anything?
No. We cannot give any credit for that.
Atopic dermatitis, again, not really the atopic history, isn't it? That's not the...
See, people have gone very specific, like allergic contact
Yes.
dermatitis.
But allergic contact dermatitis probably cannot be ruled out. I think that can be given. You're calling it, that can be given marks, but I don't know. What do you think, sir?
There is no infiltrate in the dermis.
Yeah, to call it allergic contact dermatitis, no eosinophils. But should we give it some marks rather than being very strict?
We can give some marks.
Yeah, half a mark?
Half a mark.
Okay, but not atopic. Atopic is very specific. Allergic contact is okay.
Yes.
To me. Overfacial granulomatosis, actinic damage, subacute, no. Contact dermatitis, again, same thing, 0.5. Because that's a very specific diagnosis, but still dermatitis spectrum. Angular cheilitis is a very specific diagnosis. It's not really angular cheilitis, so no marks for that. Subacute spongiotic also can be given marks. I mean, that's okay.
Yes.
Okay, sir?
Yes, we can.
So subacute and chronic spongiotic will be given, that can be given 1 mark. Contact dermatitis is very specific. I guess 0.5 mark is okay for that. Yes,
right.
sir?
Yes.
Okay. So I'm submitting this. Okay. So case number 6, 7, 8, 9. We've got 4 more cases to go. Case number 6, rash on the legs since 2 years. Nandakumar, sir, you can probably just take this up as well with Dr. Sriram. I didn't give any clinical.
Okay, sir. Sir, just on low power examination, it's more of a punch biopsy, and I feel the epidermis is relatively fine, not exhibiting much of a change, maybe some slight flattening of reti here and there. Apart from that, the superficial dermis appears very busy. There are lots of blue dots, which is specifically around the perivascular compartment and also in the interstitial compartment. So I feel something very much related to the superficial dermis. So on higher power, I even felt there are lots and lots of perivascular and interstitial lymphocytic infiltrate. I am not so sure, but I felt there is some amount of atypia, and I did suspect some amount of epidermotropism also. But even though it is not so more uniform, in 2 pockets, I just felt there is some amount of epidermotropism. And these lymphocytes are slightly appeared atypical, and they had a halo around them. However, I had a suspicion of mycosis fungoides, sir. That is the first thing I would like to rule out before thinking of anything. And I might need a clinical history of what the clinical differentials are to proceed further.
Is there any feature to suggest vasculitis?
Sir, I didn't, even though there are RBC extravasation, I didn't feel confident of calling any fibrinoid necrosis per se. So, leukocytoclastic vasculitis was out, and lymphocytic vasculitis is pretty much I feel more like a non-specific stuff, sir. But I feel the lymphocytes are having some amount of nuclear enlargement and nuclear irregularities, and that vacuolization around the lymphocytes are also there. So,
can we give the clinical history, Dr. Sasi?
So 2-year history of a rash on legs in a middle-aged man. The clinical history is capillaritis. It's typical of capillaritis, and the clinician want to confirm the diagnosis.
See, one thing which we have to keep in mind is that in this tiny capillaries in the papillary dermis, the fibrinoid deposition will not be evident, even if there is capillaritis. So the absence of fibrinoid material per se doesn't rule out vasculitis or capillaritis in this context. That is one point which we should remember. And I appreciate the comment that the lymphocytes looks slightly atypical, but to me it looks quite mature and there is some amount of migration into the epidermis. That also I agree. But basically, what I thought was that the lymphocytes were mature looking. I didn't feel that they were atypical. And I thought that because we also discussed the slide without a clinical history, I thought the histology fits in with superficial dermal capillaritis rather than anything else. We seriously didn't consider CTCL in the differential diagnosis.
I think Dr. Sriram's point is valid. When you are looking at this, you can actually see
Yes.
halos around the nuclei, but this is very non-specific in any vacuolar interface dermatitis. Now, remember, capillaritis can have a vacuolar. So there's lichen aureus, which is basically pigmented purple. So all these are part of the same spectrum, pigmented purpuric dermatosis. And capillaritis is again a synonym of it. And then you have lichen aureus, which is a lichenoid variant of it. But then you can see a mixture of this in all of them. And it is important to remember that CTCL is in fact a differential in this entity. Yes, some cases of this, it is well known that some cases of pigmented purpuric dermatosis do at some stage, 20 years down the line, may overlap or evolve, I don't know, I think the jury is still out, into CTCL, and that is well documented. But having said that, in this particular case, what you're seeing is not really epidermotropism. It is just a vacuolar interface change which is going slightly high up. The epidermis is so thin, it is difficult to call this epidermotropism. And then you have to look at it in context. There are lots of extravasate RBC. This many extravasate RBC you don't normally see in CTCL. This is very unusual. Yes, you see it in capillaritis. You'd like to see a bit more hemosiderin in capillaritis and pigment purpuric dermatosis, which would be nice. But here you're seeing more extravasate RBC than hemosiderin. So if somebody would call it lymphocytic capillaritis, I think that's okay still. But I'm not sure CTCL is in differential. There is vacuolar interface change. That is quite common in all sort of pigmented purpuric dermatosis, in my opinion. That doesn't discount the diagnosis. Nandakumar sir, anything more to add?
Nothing more. These patients needs to be followed up. I agree with Dr. Sridhar's comment that these patients needs to be followed up. But the problem is at this stage, our regular IHCs are not going to help us in any way. We have to go by the morphological appearance alone. And by morphology alone, we cannot call it as CTCL now, at least.
Yes, it has to be. CTCL has to be much more diffuse. It's not this focal to call it CTCL, and IHC is not going to help us. Dr. Sriram, do you think IHC, do you have any specific IHC in mind? Did you think that it would help? I mean, the discussion certainly will help us clarify this further.
No, sir. Clinical suspicion weighs more over than IHC from my point of view. So
yes. And what if you do the IHC and it shows a CD8 predominant pattern, all the lymphocyte CD8, would it help you?
Still, I will go for a clinical correlation, sir. Maybe CD8 positive epidermotrophic acral CTCLs are there, but still that will be more predominant in the acral sites. And loss of CD7 has been, has been found even in allergic contact dermatitis and other inflammatory dermatosis also. So I don't think loss of any T cell marker is also going to help.
Yes.
So maybe CD3 with more amount of epidermotrophism and clinical, sir. Absolutely, it's with the clinician. Whatever they say is
absolutely. I think histology, unless you are very confident there are nests in the epidermis, I didn't even mention CTCL here in this particular report that I gave, my case. I didn't even vaguely mention CTCL. And remember, atypia is often in the eyes of the beholder. If you look hard enough at a case and are you looking for atypia, you'll find it. Even in normal psoriasis, you'll find atypia. So I don't, in lymphocytic atypia especially, I don't pay much importance to my observation of atypia, to be honest. I look at the other features. Atypia itself in lymphocytic disorders is extremely difficult. I don't know. What do you feel, sir, Nandakumar, sir?
Unless the infiltrate is very dense, These reactive lymphocytes can look atypical sometimes.
Yes. I discount my observation of atypia in lymphocytic disorders.
Sir, and especially on this focus where we are just now focused, sir, I felt that the collagen bundles are getting splayed. So I thought
yes,
more of a malignant infiltrate. So
That
I mean,
can
maybe
be
I
there,
was
but I don't
biased
think that
more.
is specific. You're right. Some thickened collagen bundles may be there, but if they're there in the papillary dermis, that is more specific for CTCL. You find that more in the papillary dermis. But yes, there's no much infiltrate here. I don't think that's specific enough to call it CTCL. What do you think of this observation, sir? The thickened collagen bundles, Nandakumar sir?
And we have to take into consideration that the biopsy is from the lower limbs, from the leg, isn't it?
Yes, yes. So the biopsy, the histology, the collagen bundles can be thickened anyway. You're seeing those thickened bundles even here, down below. And if the infiltrate is in between these bundles, they will also look thickened and splayed.
I think again it goes back to the CPC. Is the
Yes.
most
Do
important
you agree,
part.
Dr. Sriram? Can you see this? If they were here, the collagen bundles are thick as well, right?
Yes.
So if the
Sure, sure.
infiltrate is
Okay, sir.
here, you would have thought that the collagen bundles are thick because of the infiltrate, which is not the case.
Okay, sir. Okay.
Do you agree?
Yes, sir. Yes,
Did we manage to convince you?
sir.
Okay. So case number 6, let's see what everybody has answered. Pigmented purpuric dermatosis, definitely 1 mark. Lymphocytic vasculitis, are we giving any marks, sir? Some marks?
Yeah, we will give 0.5.
0.5, yes. Mycos fungoides, I don't think we're giving any, unfortunately. Perivascular inflammatory dermatosis, I don't think it should be given any marks.
That's too vague an answer.
Yeah, and stasis dermatitis again is really, I don't think should be given marks because this is not the picture of stasis dermatitis. There are extravasive RBC, but that
We
doesn't
are not seeing any pigment also.
Yeah, no pigment also. Yes, exactly. Lichen purpuricus, I didn't even see that in the diagnosis list. Is that a synonym for pigmented purpuric dermatosis? I guess it is, should
One
be.
type of PPPD.
Yes, yes. So I guess we have to give that one.
Yes.
ENL, Necrobius mypotica, chronic fibrosis. I don't think we're given anything for any of those.
Majority is one of types of Majority. Majority is also one type. I mean, I've not
Majority
asked
purpura,
Majority,
yes,
but
yes. I haven't gone down there yet. Acroangiodermatitis, no. Majority purpura, yes. Lichen sclerosis, no. Chronic spongiortic, no for any of those others. Okay, so I'm going to submit this. Okay, so we're left with case number 7, 8, and 9. Let's see what is in store. So, Dr. Lavanya, I guess it's back to, you want to describe the histology here, please? This is a history, is a 28-year-old female with a lesion on the dorsum of the hand. The
Okay,
duration
sir.
is not given.
So in the scanner power, I can see a lesion in the dermis. It is almost well circumscribed lesion in the dermis with prominent pigmentation. At higher power,
Do you want to comment on the epidermis?
epidermis shows psoriasiform hyperplasia, sir.
Okay, anything else?
With focal flattening of the retiragus over above the hair follicle.
I'm not sure I would call this psoriasiform hyperplasia. I would just call it, because if you're calling it psoriasiform hyperplasia, you're implying something, it has to be either in the eczematic spectrum or the psoriasis spectrum or something related to that. This is not really, I mean, this seems to be the normal even outside the lesion, right? This sort of hyperplasia seems to be
Okay.
present even outside the lesion. So
Better
this
not to
must
make a comment that it is psoriasis or myopathy.
Yeah, what I
We
want
have
you to
not,
comment is
we have
whether
not
the
been
epidermis
told
is
the site of
important.
biopsy.
The most important thing is the lesion is not arising from the epidermis,
Yes,
right?
sir. The lesion is in the dermis.
Yeah, so that's what I want to comment on the epidermis. Epidermis looks normal, I think would be fine for most clinical purposes. The epidermis looks normal and the lesion is confined to the dermis, right?
Okay, sir.
Yeah, go ahead.
So the lesion was composed of dermal melanocytes, which are elongated, and also deeper down. So all these are stromal melanocytes. And deeper down, I could see aggregates of epithelioid-like cells with abundant melanin pigment. So I thought of pigmented epithelioid melanocytoma or blue nevus in this case.
Would you call it pigmented epithelioid melanocytoma or would you call it blue nevus? Because both are quite different.
I'll call it as blue nevus, sir, because
Blue
it is
nevus.
more described lesion,
Yeah.
not
Okay.
infiltrative.
Yeah, I think on low power, I think that it's important on the silhouette itself to comment. It's a relatively well circumscribed lesion. So it's not really well circumscribed. I would call this, I describe this relatively well circumscribed because it's an infiltrative, I'm not really infiltrative, but it's a diffuse interstitial lesion, right? For
Yes, sir.
interstitial lesions, it's very difficult to say it's well circumscribed. I would call it relatively well circumscribed, extending down the extending down the hair follicle, right? And that's
Yes,
an
sir.
important distinction. Extending down the hair follicle could imply
And
a
also over the
melanoma.
adnexa, you can see the extension
Yes,
around the
adnexal
adnexa.
extension usually is that a feature of a benign thing or a malignant thing, or does it
Benign,
tell you
sir.
anything?
No, it
Benign,
is. It can
okay,
extend in benign lesion also.
all malignant, but often adnexal extension alone, if it's there in a benign lesion, does it suggest anything else? Do you think? So as to the nature of the lesion, the origin of the lesion, or the pathogenesis of the lesion?
No, sir.
In my experience, usually congenital lesions usually extend down the adnexia.
Okay.
So
Yes.
often if it's congenital, the blue nevus could have been congenital as well. You don't know the history, but congenital lesions usually extend down the adnexia. That's my understanding of it. Yes, there you quite rightly point out the epithelioid nests here and there, and you could call it an epithelioid blue nevus for that reason. But then epithelioid blue nevus, we had a discussion before we have with this meeting. It usually has much more epithelioid cells. Here, the epithelioid cells, if at all, are very focal.
Yes, sir.
And for that reason, we thought this would best fit into a common blue nevus rather than a epithelioid blue nevus. So that's the diagnosis here. Dr. Nandakumar, sir, do you have anything more to add?
No, we will call it as a common blue nevus. Because the
Common blue nevus.
epithelioid cells, epithelioid appearing cells are not that many.
Yes, yes.
I
Dr.
don't think
Sriram and Dr. Payal, anything else to comment?
any other differential diagnosis.
Sir, I per se kept obviously both the DDs, sir. Pigmented epithelial melanocytoma and blue nevus. On low par, I kept blue nevus only. But going on to high par, I felt lots of epithelioid cells are there, which is slightly not so common in a common blue nevus. So I then felt more this fits more towards an pigmented epithelial melanocytoma because in blue nevus we expect lots of spindle-shaped dendritic melanocytes and few epithelioid cells is what I remember reading. So when someone sees lots of epithelioid cells, I preferred an pigmented epithelial melanocytoma over a blue nevus. Obviously, clinical inputs are also needed.
Do you know the clinical, what is the other name for pigmented epithelial melanocytoma?
Previously, it was called epithelioid blue nevus, sir, but now it has been separated out.
Is there any other synonym?
I'm not aware of, sir.
Animal type melanoma is the other name for it, and these all have been clubbed into one entity. Usually they present with extremely dark lesions, and they're quite big actually, and they're very cellular. They're much more cellular, and often they can have benign metastasis also to lymph nodes. That's a very dark lesion. Clinically, it's not a small papule, often larger lesions actually. And usually buttocks are the usual presentation actually. So pigmented epithelial melanocytoma, if you're calling that, it has slightly more implications because it's usually in the cusp. It's very difficult sometimes to differentiate that from melanoma. That is the degree of epithelioid differentiation you see there.
Okay.
In my experience, and much more deeper lesions. They're not as superficial as this. Much more deeper and darker lesions, and not usually just a papule.
Okay.
So that's my that's my understanding of it, and that's the reason why it's not a pigmented epithelial melanocytoma. Dr. Nandakumar, sir, what are your thoughts on this?
Let us see the answers given. I
Yeah, yeah.
think perhaps, yeah.
So if 5 people have called it acral melanoma, obviously not. Pigmented epithelial melanocytoma is there, so we need to decide on this.
I think we have to give some credit for that.
How much credit do you want to give?
Yeah, based on our discussion, 0.25.
0.25, yes. My My mentor in UK, where I trained, Dr. Al Evans would have given this 0 if I had called this pigment epithelial melanocytoma. But I think for the Indian setup, it's okay just because we see this very rarely. I think that's okay. Epithelioid blue nevus, are we giving, I guess the fact that they called it blue nevus is good.
Yes.
Epithelioid 0.75, do you think is okay?
0.75. 0.75.
0.75, yes.
No,
Melanocytic
but both
nevus,
are considered synonymous, no, sir. Pigmented epithelial melanocytoma and epithelial blue nevus are considered synonymous. So if one gets 0.75, then the other also should get 0.75.
pigmented epithelioid melanocytoma is actually, it's synonymous in the sense that some people have used it as synonymous. So for that reason, animal type melanoma is also synonymous, but it's not synonymous. They've clubbed them all together. So now previously some regions people have called it epithelioid blue nevus, some people have called it pigment epithelioid melanocytoma, some people have called it animal type melanoma, but they've all now been clubbed. Epithelioid blue nevus is now a slightly different entity. Pigmented epithelioid melanocytoma and animal type melanoma are now considered a single entity now. Epithelioid blue nevus, what people used to call it previously, is now been segregated, and now only blue nevi with epithelioid cells. Not usually the animal type melanoma. It should not be that pigmented. And in animal type melanoma or pigmented epithelioid melanocytoma, all the epithelioid cells are deeply pigmented. The cells are epithelioid, but they're so deeply pigmented, unless you actually, remove the pigment, you can't really make out even the epithelioid nature of the cells. That is the spectrum. That is my understanding of it. Anyway, we can revisit this, but that is my understanding of it from what I have been taught and the cases I've seen. Pigmented epithelioid melanocytoma and animal type melanoma are one entity. Epithelioid blue nevus is usually the blue nevus that has more epithelioid cells, but not so pigmented as this. So I don't think pigmented epithelial melanocytoma should be given, but we can give it 0.5. I don't have a problem with giving it 0.5. What do you say, sir? Nandakumar sir, you can take a call on this. Nandakumar sir, are you there?
Yeah, I'm here. I'm sorry. I go. Yeah, we will give it 0.5.
0.5, okay. We'll upgrade it to 0.5. Okay. I guess Dr. Sriram has written a pigment epithelial melanocytoma, so some influence of the panelists is there. Melanocytic nevi, papillary plaque type blue nevi. It's not really plaque type. It's just a papule. So I don't think that should be given full marks, but 0.75 is okay for me. It's very specific. I don't know why that entity is even there in the differential. I should probably remove it.
0.75.
Dermal melanocytosis, common blue nevus is what I would give 1 mark. Exophilia, acanthosis nigra, congenital melanocytic nevus compound. I don't think we're giving any of these any marks. Cellular blue nevus, again same as epithelioid, 0.75, sir.
0.75.
Blue nevus like melanoma, pigment, no, we're not giving any of these any marks. Okay. So last two cases.
Sir, can we give dermal melanocytosis some mark?
Dermal melanocytosis is completely different, no? What is dermal melanocytosis? What is your understanding of dermal melanocytosis?
There'll be stromal melanocytes.
This is a
Dermal
blue nevus.
melanocytes.
I don't think there should be any other differential, to be honest.
Okay. But that also deals with stromal melanocytes, no, sir?
Yeah, but I don't think so. What do you think, sir?
No, we cannot give in marks.
Yeah, okay. So last two cases, let us quickly go through this. Nandakumar, sir, you can probably go through this with Dr. Payal. Case number 8, 60-year-old male, painful itchy lesion about right ear for 10 years. Lesion resolving and recurring specifically in one location for 10 years. Similar complaint treated with excision by an ENT surgeon. So this is the clinical picture, bit distorted, but you can make out the erosion here with loss of hair. And the DDs given were pyoderma, gangrenosum, or scarce hypoidosis. Yes.
What I saw is there is epidermis and dermis, and epidermis is sloughed off at one end, and probably ulcerated because of the ulceration. And underneath, there's a lot of inflammation with some fibrosis, minor fibrosis. So I would like to see there's also I can see the separation of the epidermis. So one end is separated from the dermis, underlying dermis, and dermis has a lot of inflammation, which again I like to go up higher to see what this inflammatory infiltrate is about. So,
Any diagnosis?
sir, I was towards pustular dermatosis spectrum, but then there is only one lesion, so I or post.
It has been there for a very long time, the lesion. And
So
at the edges,
hello.
at both edges of the sections, what are we seeing?
Sir, I missed your last line.
I
Hello.
didn't get you.
Sir,
Can
I
you
missed
repeat?
your last line. You were saying something. I missed it.
At both edges of the section, what are we seeing?
So there is ulceration and the separation of the underlying dermis from the overlying epidermis, and
Do you think that it is artifactual or could it be pathological? Can we go closer? That separation of the epidermis from the dermis, does it look artifactual or is it pathological?
not very sure about it, sir. Not very
Because
sure.
I would call it pathological because you just when we look at closer, the basal cell layer is very clearly seen the roof of that separation. In an artifact, this is just from my experience. In an artifactual cleft, the cleft line would be more straight. Here, that contour of the cleft is there. It is maintained. The normal contour of the dermal papillae with the overlying basal cell layer is clearly maintained. So we have to give, especially in a patient who has been having the lesion for such a long time, we have to give some importance to that finding. And if it is artifactual, why it has occurred on both edges of this section. So I personally feel that this is a subepidermal separation. I think that is the basic pathology in this skin biopsy. There is a subepidermal separation with intense inflammatory cell infiltrate in the upper dermis. It is not, it is not artifactual. Here, I think on the right hand side, that is very, very evident. We have to. Can we go closer to that cleft, Dr. Sasi? That cleft area? Yeah, just a little bit more. Higher, higher, higher. Yeah, and it is filled with this material also. You can see the basal cells forming the roof of the blister. So it is a subepidermal blistering disease. If it is a subepidermal blistering disease, what does it fit in with?
From the list of subepidermal blistering disease, be acquired also not bullous Ellis, not linear IgA doesn't present like this. And pemphigoid, I mean, the, the, they're all the immunobullous variants, so it is not fitting into any. Then I'm very sure of this.
If it is pemphigoid, what type of pemphigoid could it be?
Good, pemphigoid. There's some rare variant of bullous pemphigoid. I'll have to go and check if it can present on scalp as a solitary lesion. There's other.
Can we call it a cicatricial pemphigoid?
Yes, that is one. Yes, but then we'll have to check the ocular mucosa and the oral mucosa if there is anything. It's a solitary lesion on the scalp fitting with cicatricial pemphigoid without any mucosal. So the other name is mucosal membrane. Mucosal membrane pemphigoid. So we'll have to check if there is any history of ocular or oral lesion.
I'm sorry, there is some background disturbance is there. But basically, we agreed on the finding that this is a subepidermal blistering disease, and taking into account the long duration of the lesion present on the scalp, histopathology wise, a possibility of cicatricial pemphigoid could be considered. That was our consensus.
And also there is a lot of fibrosis you can make out here. It's fibrotic scarring. That's the nature of the lesion because it's a very chronic lesion. And that's a typical presentation of cicatricial pemphigoid. Actually, you don't often see oral mucous membrane pemphigoid is different. That may or may not have scalp involvement, but I've seen a lot of cases of purely cicatricial pemphigoid occurring in the scalp without oral mucosal involvement. That is also a common, not an uncommon presentation. Have you seen such cases, sir, before, Nandakumar, sir? Sir, are you there?
By and large, this is comparatively more rare compared to our conventional bullous pemphigoid. So we will call this a cicatricial pemphigoid. I have seen few cases, but not very common, at least in our place.
Yes, not very common. Actually, I saw a lot of cases in the UK, actually, a lot of cases of isolated, and that's the reason as soon as a patient, even the clinical wise, I thought this was clearly cicatricial pemphigoid when I first saw the clinical picture, and histology just confirmed that actually. So, yeah, let's see. Any other
In these patients, do you then go ahead and confirm it with DIF or
Yes,
IF?
yes. DIF is very important to do. Yeah, DIF is an important test to be done, and it would confirm the diagnosis here in this case.
Was it done in this case, sir?
Not yet. This is a very fresh case.
It's a new case.
So this is just a sign note that I've just put in. But I'm 100% certain about the diagnosis, both in the clinical and histology. Chronic lesion, single lesion on the scalp, erosive lesion, erosive plaque. There's really no other differential. Can you think of any other clinical differential that would present like this? Do you have any other clinical differentials?
No, this case only sort of was a lot of time to again think over.
I mean,
the only difference is dermatitis artifact.
It is a difficult case to make a diagnosis. As you said that it will be ideal if we could confirm with the DIF, but I mean, consensus was that we could call it a cicatricial pemphigoid.
If somebody would call it dermatitis artifact, I don't think I would have a problem with that because I haven't given DIF. What do you say, sir? I don't know if anybody has called it.
We cannot give full marks.
Some marks may be given, I guess. Let's see. So sarcoidosis, I don't know why they've called it sarcoidosis. Chronic DLE, I don't think so actually. Lupus vulgaris, bullous morphia, pemphigus vegetans also, unfortunately, no. Nobody has called it artifact, is it? Granuloma faciale, pustular dermatosis, bullous lichen planus, lots of varied answers actually. Scarring alopecia. So somebody has called it bullous pemphigoid, but nobody has called it. So nobody's getting any marks, unfortunately. Are you giving any marks for any of these answers, sir?
I think for bullous pemphigoid, we will have to give some credit. That person has a.
But then but clinically, it is not bullous pemphigoid. It's not bullous pemphigoid clinically.
No, what I'm saying is that person has identified the subepidermal split as pathological.
Okay, fine, fair enough. How much are you going to give?
0.25.
0.25, I think is fair. Yes, okay. Okay. But then bullous lichen planus is also subepidermal split, but it's not lichen.
No, you cannot call it as lichen planus, no?
Infiltrate is quite till mid-dermal level, no? The infiltrate is also quite.
Yes. Okay, so I'll close this case and then we'll go to the last case and see what happens. Case number 9. Oops. So case number 9. I think this is fairly easy, Dr. Sriram. You can probably quickly close this case. Very easy case. The clinical history is a 40-year-old woman with a papule nodule on the anogenital region. Typical history: posterior vulva, 2 years, firm, non-tender, 1 centimeter in diameter, no ulceration, no bleeding. Dr. Sriram?
You're mute. You're on mute, Dr. Sriram.
Okay, sorry. So the slide shows a skin-covered tumor, sir. The tumor is predominantly dermal in location, and it is relatively circumscribed. It has a very thin wall, and the tumor cells are predominantly arranged in tubular papillary pattern, and on hyper we can see two population of cells: the luminal cells, which are having a small cuboidal cells with with a decapitation secretion, and the periphery shows a very clear vacuolated basal cell layer. So the diagnosis was hydradenoma papilliferum.
Yes, I think this cannot get any more typical than this, and you can see the nice apocrine secretion as well. Any other comments?
Very typical.
Yeah, Nandakumar sir, are you there?
It is on me.
Oh, Nandakumar sir, are you there? You can't see, maybe you've stepped out. Okay, fine. So let's see what the answers are. There's only one answer for this anyway. So, hydradenoma papilliferum, 20 of you have given the right answer. I don't think you're giving any marks to any of the other answers because this can't get any more typical than this. Okay. So, yeah, that's it. So we'll release the marks once I've just made sure that there's no errors in the back end. So, well done. Any other comments from the panelists? What do you think of the cases, the discussion?
So first case, I have a small query. I mean, which I read through literature. They said late stages of lichen nidus can have lots and lots of epithelioid cells per se. But I think lichenoid inflammation is the only one that is very much against a lichen planus. But apart from that, just based on the epithelioid cells, I mean, I don't think
I
you can
think
just
that is
call it.
no. Lichen nidus, I tell you why. Lichen nidus, this much amount of, I guess if you see a lot of cases, you'll understand this much amount of epithelioid cells, and that too with such eosinophilic cytoplasm. That is other quantifying, that is other qualifying thing that we made in the description, that these have eosinophilic cytoplasm. No other, granulomatous disorder with normal histiocytes in a granuloma will have eosinophilic cytoplasm, and that's a clear distinction between histiocytic disorders and the just a granulomatous infiltrate with histiocytes.
Okay.
And these are all in clusters. In a granulomatous disorder, you see lots of lymphocytes. Where are the lymphocytes here? These are just a cluster of histiocytes. You see lymphocytes vaguely here and there, but this is not a lichenoid granulomatous disorder. In lichen nitidus, it's a lichenoid granulomatous. Here, seeing the basal layer is fairly intact. It's not lichenoid by any means. And usually in lichen nidus, unless it's a giant lesion, it's usually confined to one papilla. And clinically also, if you look at the clinical picture, these are almost nodular lesions. You don't get this big lesions in lichen nidus. They're actually very micro papules in lichen nidus. The clinical, you have to, and also the other most important thing, we did discuss this actually when we were discussing eyelid lesions. Look at this. You don't get eyelid lesions like in nidus.
Okay.
That's one more clue to this being a histiocytic disorder.
If I may add one point here.
Yeah.
There usually those lesions of lichenitis, they're very grouped together. Somewhere you would see that they're grouping together, those lesions of lichenitis.
I think that's a very important point. There is absolutely no grouping here.
Yeah.
Sometimes you can see cognirization also. So clinically per se.
Yes.
Yeah, clinically actually
all the photos
some of the cases of lichen nitidus would look like lichen planus, isn't it? Cognirization and
yes.
That is the clinical DD. I mean, we do appreciate your comment, Doctor. But for the points which Dr. Sasi discussed, we cannot call this as lichen nitidus. First of all, it is not lichen. And second thing, the nature of the infiltrate, the architecture of the lesion, even though at the scanner view, it does, as I said in my discussion, one could consider lichen nitidus as a possibility, but when you go closer, we have to make the differentiation that this is not lichen nitidus and this is something else. It is not sarcoidosis and it's something else, not a granulomatous disease.
And that's why it's very important as pathologists, and I'm glad that Dr. Sanjay and Dr. Lavanya, you're here as pure pathologists, and that's where the role of CPC comes, and that's why it's very important as pathologists, reporting pathologists, you have a lot of clinical knowledge. You need to go back to the clinical, look at the clinical, and that's very important. If you're only doing histopathology reporting, this can get very confusing, and that's why we're having these CPC sessions, because it's not just histopathology. Because in that lip case, that looks like a psoriasiform dermatitis, and that looks like you can report a psoriasis if that was if you didn't read the history properly. So that's where the importance of CPC comes in.
Yes, sir. I agree.
Thank you. Thank you, sir.
Yeah. I'm glad you raised that point, Dr. Sriram, and that's very important for everybody to understand. That's an easy mistake to make.
Thank
Right.
you, sir.
So thank you all for joining in, and hope to see you next month, same time, last Wednesday of the week. The yesterday was Vinayak Chauthi, so we didn't actually have a meeting, so it postponed to Thursday. But thank you all for joining in, and see you next time.
Yes, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Thank you,
Thank you,
Nandakumar, sir,
panelists.
and
Dr.
Shashi Kiran, sir.
Thank you. It was very, very, very interesting and even a learning process for us also, discussing cases with you people. Thank you, Dr. Payal, and thank you, Dr. Sriram. Bye.
Thank you, sir.
Thank you, sir. Thank you, sir. Thank you, sir.
Bye.
Thank
Bye.
you, sir.
Bye. Can we close the meeting,
Yes,
Dr.
sir.
Sasi?
Yes, sir. Close it.
Perhaps Dr. Manoj forgot about it.
No, I called him and I didn't pick up. Maybe there was some emergency. We don't know.
Okay.
Okay,
Right.
sir. Right. Okay.
Yeah. Bye. Bye.
Bye-bye.
Nice discussion. I thought it was very good discussion.
Yes,
I
yes.
mean, because being pure pathologists, their inputs were also, very
Yes,
interesting.
yes.
Their viewpoint,
Yes. I think that was good actually to discuss all that, because
Yeah.
it's all learning. And
Yes.
rather than having a normal discussion, this is very interesting.
Yeah.
Okay, sir. Right.
Okay.
Bye-bye.
See you.
Bye.
Bye.
Bye.